So now we'll end this session by watching a video, brief video on Dr. Ranjit Rai Chaudhary again.
Today is a red letter day for all of us who believe that traditional medicine of India is on its way back to becoming the center point of therapy in India. And as I look after also the 10 countries in the WHO region in the World Health Organization.
That was Chulalongkorn.
How to prevent litigation. You know, that's all what we want. We want our doctors should work in peace and not be harassed. We want our patients to be happy. You cannot, based on my experience, you cannot regulate ethics. You cannot legally do it. You can try. It has to be from within. Yes. It has to be from within the industry. It has to be self-regulation. There is no other way in the long run. And that is why a code of conduct is so very important. So in our aim to usher in health assurance in this country, we are aiming at providing 50 drugs, including diabetic drugs, as far as possible in number, free to every citizen of India from birth to death.
let me conclude this session, just reminding ourselves that we are proud that Professor Ranjit Roy Chaudhary actually ancestrally hailed from this city. His ancestral house is only maybe 30 kilometers, 40 kilometers away from this place where we are standing today. That place is called Behala, Barisha. And he hails from the Saborno Rai Chaudhary family, which has a huge, great heritage in Bengal. And I think just one year prior to his death, he left us in 2015. He came in 2014 and he gave me the responsibility of visiting his relatives in his place, and then we spent a couple of days together in 2014. And I was accompanying him, and there was a ancestral temple of his which we visited. So it was a great memory to many of us who were fortunate to accompany him and share some few moments. He was, the other part of his personality is he was hugely affectionate, so smiling, and I have hardly seen him to express his annoyance, to be angry with anybody, to shout at anybody. He was a great personality. So thank you, sir. Your blessings will be always with us, and we will take this association forward. Your life always reminds us what commitment we should fulfill towards the society. Thank you again. Thanks.
Next, we would like to inaugurate the abstract book for the conference. And for this occasion, I would like to invite our all respected dignitaries onto the stage. First, I would like to invite Professor N.R. Vishwas sir to please come to the stage. Professor Debasish Hota sir, please. Professor S.P. Dhaneria sir. Dr. Sanish Davis sir. Dr. Shoival Mukherjee sir, and respected Professor Shantanu Tripathi sir. So it is a proud honor to inaugurate the abstract book for the second conference of the Association of Clinical Pharmacologists of India. Thank you so much, sir. We'll continue with the program, sir.
Some emergency happened to one speaker, so we had postponed that session. And tomorrow we have a talk from Professor Usha Rani Pingali Madam. We had preponed two talks. One is, this session will be two lecture session. One is by Dr. Anand Srinivasan and another is Professor Debasish Hota sir. So may I invite now to chair the session Dr. Shoival Mukherjee sir. Would you please chair this session? And in the meantime, I just want to thank Professor Nilima Khirshagar Madam. Madam has made a comment in the chat box that congratulate Shoival sir for his wonderful lecture. So thank you, Madam. So we'll hear from you also in the session that is the theme lecture for this conference. We'll wait for that. So now I request Dr. Shoival Mukherjee sir to start this session.
We've just crossed 12 o'clock, so good afternoon, everybody once again. We have two lectures in this session. The first lecture is by Dr. Anand Srinivasan, Adaptive Clinical Trial Designs. Anand is an eminent clinical pharmacologist who I have had the good fortune to interact on several occasions, and every time I listen to him and his hold on the newer areas, some of the areas that I talked about in my lecture. So like Shambhu, Anand is another person that I'm always inspired by, and it will be a pleasure to listen to him. Anand, you're up for the first lecture.
I also thank the organizers for providing me this opportunity to talk on this topic, adaptive clinical trials. So, let me move into the topic directly. So, first of all, when we talk about adaptive clinical trials, of course, we can understand a lot of theoretical aspects of it by going through any review articles. Okay, but when it comes to the implementation of adaptive clinical trials, especially in the academic settings, so people think that this is a domain of big pharmaceutical industry where we cannot do adaptive clinical trials, and it's just of some theoretical relevance to them. But here I just want to give our experience in conducting adaptive clinical trials in the academic settings. We will share our own experiences. Of course, I will also include certain other theoretical concepts which we have not yet involved in. So with this, let me go into the topic. So, of course, this audience does not need an introduction of what is the definition of a clinical trial, but still anyways, I will go through it. It's any study which assigns the participants randomly to interventions and evaluate the effect of these interventions on health outcome as per WHO and many other clinical trial definitions also convey the same message. However, when we talk about adaptive designs in clinical trials, okay, first of all, let us look into the traditional fixed sample design. So what happens is, whenever we start conducting a clinical trial, of course, we design a clinical trial and then execute it. Okay, so we plan and execute it as per the protocol. The protocol does not allow any flexibility during the course of the study. So that is the traditional fixed sample design. However, when we talk about the adaptive designs, okay, so we incorporate this flexibility itself in the protocol. Basically, these studies, as per the outcomes during the course of the study, the design will be altered as per the rules pre-specified in the protocol. So basically, we design the study, we conduct the study, we review in between, and then adapt and change the design of the study a little bit, and then move forward until the final analysis is done. So it has a lot of this concept of adaptive clinical trials has a lot of advantages. Of course, any concept which advantages will have certain disadvantages also. We will come to that later. Okay. So to reiterate, any any design which allows the change in the course of the study based on its performance in accordance with the pre-specified rules, which is what I was mentioning until now. Okay. So if we look into the broad categories of clinical trials, we can divide them into parallel studies, crossover studies, and factorial design studies. However, when we look into the adaptive trial designs, it's usually applied in parallel designs. I'm not saying that it cannot be applied in crossover and factorial, but if you look into the publications, many of the adaptive trial designs will be adaptive designs will be based on the parallel designs. And let's also consider the other aspects of designs, which are randomization, allocation concealment, blinding, control, single and multi-center. These are the other considerations of when it comes to when it comes to designing clinical trial, of course, again, this audience does not need any explanation for this. In the other aspects of the designs, only randomization is where we can, adapt and take the trial further. Now, there are innumerable types of adaptations, but all the adaptations are based on certain basic adaptations, which I will enlist now. We can, build other adaptations based on whatever the adaptations which I am going to display. The first is group sequential testing. The second is adaptive randomization. The third is continual reassessment. Fourth is sample size re-estimation. Fifth is multi-stage design. And the sixth is population enrichment. Okay. So we will see one by one. We have experiences in group sequential testing, adaptive randomization, and continual reassessment. However, we have not yet tried the sample size re-estimation, multi-stage, and population enrichment. So first, let us talk about what group sequential testing is. So group sequential testing is nothing but explaining the concept of interim analysis in a deeper manner. Okay. So basically what happens is, so we do interim analysis in a group sequential testing based on, or to determine or to evaluate either the efficacy, that is how much the drug is, or experimental therapy is working, futility, that is how much, that is whether, it depends on futility means that the drug is not working, and safety, it's understandable what safety outcomes are. Now, when we talk about the group sequential testing, it's always about alpha spending. So alpha spending is nothing but a concept where whenever we perform analysis multiple times in the same study, the concept of accumulation of alpha error over time has to be reduced, so that all the analysis together will contribute only 5% of alpha error. So we spend certain amount of alpha at every analysis. Okay, so that is called alpha spending. So this concept of alpha spending can be defined by either Pocock's function or O'Brien's Fleming function. Yeah, we'll come to that. Okay, and this concept can be applied for your beta spending also, because both are different types of errors, and it has to be distributed across various assessment points so that the cumulative alpha and beta remains the same as per our design. Okay. Now, generally alpha spending is for efficacy parameter and beta spending is for futility parameter. So that's what the group sequential design dictates. So this is our one of experience in conducting an group sequential method, wherein we compared the in one of our students' thesis, Dr. Gayatri's thesis, where we saw let's say we will not look into the scientific aspect of it, but let's consider we had an experimental group and control group for a regimen evaluating the management of chemotherapy-induced nausea, vomiting. So in that clinical trial, what we did was, we had planned for a total of 3 analyses. So the total sample size of the study was 94. So we can see that we have defined our, just a minute. Yeah. So here we defined both the efficacy and futility boundary, involving alpha spending. The red line is alpha spending and the blue line is beta spending. Okay. So basically the y-axis, the x-axis mentions the sample size which has to be achieved for the various interim analysis. So we had designed that the first interim analysis will be done at 44 and the second at 70 and the last at 94. And on the y-axis we have the critical value or Z values. Okay. So basically, so whenever we talk about group sequential testing by defining alpha and beta boundaries, we always perform a one-sided test, two separate one-sided tests for both alpha spending and beta spending boundaries. So whenever both the z values falls between these two boundaries, we take the study forward, and whenever there is a breach on either side, we stop the study. Okay, so if the z value crosses the red line, then we stop the study because of efficacy, and whenever the z value crosses the blue line, we stop the study because of utility. Okay. Here we didn't consider the group sequential testing for the safety part, and that's allowed, not an issue. So the thing is that this study is already completed, and we had to stop the study at the second interim analysis because the endpoint crossed the futility boundary. So basically our experimental therapy was as good as the control or the standard of care. So this is one of the experiences in our group sequential testing. So next we will go into this adaptive randomization part. So adaptive randomization can be either, can follow either the frequentist approach or the Bayesian approach. Okay, right. Now when we talk about the adaptive randomization, what is the principle behind this adaptive randomization? The basic principle is being to reduce the exposure to ineffective treatment. Okay, so we adapt the randomization based upon the, so we that is we change the randomization, that means we change the allocation ratio favoring the better response group, of course in a blinded manner. The procedure is the allocation ratio is changed as per the response, and the setting is can be both Bayesian and frequentist. Okay, so we have not done Bayesian adaptive randomization until now, but we have tried frequentist approach in adaptive randomization in one of the other thesis. Again, this is also, we had an experimental therapy against a control therapy for the management of chemotherapy induced nausea vomiting by Dr. Madan. His thesis is also completed now. So this is the basic framework of adaptive randomization, which is combined with actually group sequential method. Okay, basically here we have, it's a combination of two adaptations, that is we had combined both the group sequential method along with the adaptive randomization on a frequentist framework, not on the Bayesian framework. Okay, so what happened was, so in this study there were 4 analyses, that is 3 interim and 1 final analysis. At the end of each interim analysis, we saw what the Z value was for efficacy. So this again, this adaptive randomization was planned only for the efficacy outcome. So if the Z value at the end of the first interim analysis, if any interim analysis falls less than 1, then we did not change the allocation ratio. If it was 1 to 1.5, the allocation ratio change was 1 to 1.5. If it was from 1.5 to 2, the allocation ratio was changed to 2, and if it was greater than 2, the allocation ratio was changed, has to be changed to 2.5. Right. So, and how to change the allocation ratio? Because if you all understand the principle of the allocation ratio, whenever the allocation ratio is changed, actually the sample size itself will change. Okay, so that's how we will have to change. This is the way where we change the sample size based on the allocation ratio. Now again, as I told previously, this study had both the adaptive randomization part and the group sequential part incorporated within the same study. So in this study also we can see that the total sample size was 84, and we had 3 interim analysis planned, one at the end of 30, one at the end of 47, and one at the end of 66. And if the z values for both of these fall between these 2 lines, we will carry the study forward, and if the z value breaches the boundaries, then we will stop the study, right? So in this study what happened was, at the end of the first interim analysis, the z value fell between 1.5 to 2. So we had to change the allocation ratio to from 1 to 2:1, where we that is we had implemented the adaptive randomization on the frequentist manner. And at the end of second interim analysis, the the experimental therapy breached the efficacy boundary, and so we stopped the study. So in the first study we stopped the study because of futility, and in the second, even before attaining the complete sample size, we stopped the study because of efficacy. Right. So what would have happened, how the boundary would have looked? In both the studies, it was like we followed this O'Brien-Fleming boundaries, O'Brien-Fleming function to define the alpha and beta spending boundaries. So this is how the boundaries would have looked if we had defined both the alpha and beta spending boundaries, if we had used Pocock function. Okay. So again, the red line for efficacy parameter and the blue line for futility testing. Okay. So this is just an demonstration of how the alpha is spent at every interim analysis. Okay. So if it is Pocock, we can see that at the first interim analysis we spent 0.02, in the second it is 0.01, third it is 0.009, and fourth is 0.075. So basically, like, it's almost inverted in O'Brien-Fleming function. Okay, so basically, because the sample size is very less, we cautiously spend the alpha. We spend only very little alpha in the first interim analysis. And basically, if you add up all these things, it will become 0.05. So usually people recommend O'Brien-Fleming more than the Pocock because the alpha is spent really in a small amount, that is conservatively, because the sample size are comparatively less when it comes to O'Brien-Fleming analysis. And I also missed to tell one thing, because we changed the sample allocation ratio to 2:1, the required sample size actually shot up from 48 to 54 because we changed the allocation ratio. Yeah, that was also one of the change in the study design which happened. Okay. So this is an example where adaptive randomization was implemented on the Bayesian framework, wherein so they had compared 3 anti-cancer regimen in the management of adverse karyotype acute myeloid leukemia. So basically what happens with the adaptive randomization on a Bayesian framework is at the end of evaluation of each and every patient, based on the posterior probabilities which are updated based on the response from the previous patient, the allocation ratio is changed. Okay. So what happened was, in this study, after the end of 24th, after the recruitment of 24th patient, the third treatment arm was completely removed from the study, and after, the allocation ratio remained stable after the 27th recruitment, which favored heavily the idarubicin and cytarabine arm. So this is one example for adaptive randomization on the Bayesian framework. So the next adaptation is continual reassessment. That is, again, this continual reassessment is usually done in phase 1 studies. So we helped in designing a phase 1 study. Still it is not at started. In this phase 1 study, that based upon the initial data from the preclinical studies, we assumed certain prior probabilities, and then using the empiric Bayesian modeling, we updated the posterior probability for the various doses which are planned in the study. So, and after the end of evaluation of each and every participant or volunteer, the posterior probabilities will be updated based upon the response or based upon the incidence of adverse events from the previous participants, and thereby the thing is that with this approach we can achieve the the 33% ADR rate soon, very soon, because when a dose indicates the probability of say less than 0.2, we can just skip that dose and go to the next dose. So thereby the dose escalation will be steeper and fast. Okay. So, say for example, in this study, if the scenario was something like the first dose, there were 2 participants without any adverse events, and in the second dose, there were 2 participants were first had 1 event and second had no event, and if the third patient had no event with the first participant and the second patient of the third dose had some adverse events, the updated posterior probabilities were something like this, wherein you can see that after the third dose, the fourth dose showed probability of greater than 33%, so it is not advised to escalate to the fourth dose. We should stick to the third dose and start giving the third dose to more patients to fulfill the regulatory requirement. So basically, here you can observe that the dose escalation has happened really fast with less number of participants. So that is what this continual reassessment method in phase 1 studies are about. Okay. So then we have this concept of sample size re-estimation adaptation. In this, what happens is it's straightforward. As it mentions that sample size re-estimation, what happens is that after every interim analysis, the sample size can be recalculated. But the difference is here is in the previous example from one of our thesis, I told that after the first interim analysis, we recalculated the sample size because the allocation ratio was changed. Here, the difference here is, here the allocation ratio will not be changed, but the effect size will change based upon the interim analysis, so that the sample size can be recalculated. So this is one form of adaptation, and it can be allowed provided we define this adaptation in the protocol itself. So there are many examples for this, so I am not putting in any example. And this adaptation multi-arm and multi-stage is actually forms a framework for your seamless transition for phase 2, phase 3 studies, and those seamless designs actually follow this adaptation only. Okay, so usually this adaptation done in dose finding studies. So as simple as that, the dose which is effective is selected and the evaluation is continued in the next stage, and the ineffective dose arm is dropped post the interim analysis. So this is a protocol from a publication where telmisartan and insulin, telmisartan was evaluated for insulin resistance in HIV patients, this trial called Taylor. So here we can see that in the stage 1, they had planned to study all the 3 dosages, that is telmisartan 20 milligram, telmisartan 40 milligram, and telmisartan 80 milligram daily. And in the stage 2, they mentioned that post the interim analysis, they will drop the study arm, and if the drug was very effective and recommend it for phase 3, or if they will drop it if the, the dosage was not working, and they will evaluate further a little bit more before recommending it to the phase 3 if the efficacy was between, satisfactory and unsatisfactory, so that they can finally decide whether the dosage can be taken up for phase 3 or not. So population enrichment, this what happens is in this design, if you want to, in this adaptation, if you want to put simply, even after the randomization has occurred, the investigator can determine whether the participant can get into the study further or not. So another, of course, there are various tools which are used, but however, the simplest example here will be the removal of placebo responders. Here, this is an example of population enrichment adaptation, where rizatriptan was evaluated in pediatric migraine. Here, you can see that after the randomization of patients, when they found that there were 100 responders in the placebo arm, so they were removed before randomizing them further with the rizatriptan and placebo. So this is one form of adaptation technique. So basically, based on these adaptation techniques only, the specialized cancer clinical trials for personalized medicine are being conducted. That is, we have basket trials, we have umbrella trials, we have platform trials, and these are, if you actually look into these three designs themselves, require a big lecture and big discussion. So I'm not going to discuss about these designs. But if we go through the designs of these studies, you can find any of these adaptations being incorporated as the study progresses. So if you look into the actually advantages of the adaptive clinical trials, of course, when it compared to the fixed sample design, we definitely, the amount of resource required is less. Even for example, from our thesis study only, where we had actually stopped the study in between, so that we could save a lot of resources and also the time to complete the study. So the trial was, we were able to complete the trial yearly, and also limited exposure to either suboptimal efficacy and ADRs for the participants. And this is very important from the ethical point of view. Basically, it is definitely unethical for exposing the participants to suboptimal therapy or to ADRs. However, the limitations being the expertise availability, of course. It is to implement this, actually many of these whatever the adaptations we did, actually we implemented with the help of our programming language, because there are no pre-specified tools openly available, and the pharmaceutical companies may have their own proprietary tool within their system, but there are no open tools available for making this simple. So we need to code the group sequential designs, adaptive randomizations, or the continual reassessment with the help of our programming language. And this is not a very big limitation at the academic setting, but resource redistribution will be an issue when it comes to multicentric studies for a big pharmaceutical company. So yeah, that's all about an introduction to the adaptive designs in the clinical trials. Thank you.
Any questions for Dr. Srinivasan? Yeah.
A simple clinical trial design wherein we incorporate a stoppage criteria for utility or your efficacy for that matter. Will that be considered as an adaptive design? Because designs like this have actually been practiced previously also.
Yeah, of course, it's practiced. I have never claimed that it is never practiced. Of course, it is practiced.
So
yes.
it is.
So provided we define based on these boundaries, alpha spending boundaries, not without including the alpha spending. If we just define an interim analysis without considering the alpha spending, then it cannot be considered actually.
Okay.
Yeah, that's what my take is. Yeah.
Okay. And sir, for the considering the criteria for the stoppage, is there any criteria for selecting O'Brien, Fleming, or Pocock, or is it more of a convenience?
It's not about convenience. It's the way you look. It's about again the perspective. Okay. As I told previously, in the O'Brien Fleming, the spending, that is the error spending, be it alpha or beta, in the beginning when the total sample size is less, is very less, which is preferred actually, because that will be less prone to errors in O'Brien. But Pocock, it usually what happens is similar amount of error is spent throughout the study. So that is the thing. Otherwise, it's about if we can justify why we are using it, it is fine.
Okay.
That's the thing. Yes.
Okay. Thank you, sir.
Any other questions for Dr. Srinivasan? Are there any questions in the chat box? Who has access to the chat box?
No questions.
No questions there. No. Right. So, yeah, please.
PhD student.
Keep it closer to your mouth, please. Yeah.
I am in
Very close, very, very close. Yeah.
I am second year MD So I have a question. What is posterior factorial? You mentioned in your lecture.
Posterior probabilities.
Probability.
Posterior probabilities is a concept in Bayesian design, Bayesian analysis. So what happens is, in the traditional frequentist approach, we don't take the previous knowledge while analyzing the data. So but when it comes to Bayesian analysis, we take the previous knowledge into consideration, and from the results of the present study, we update the previous knowledge with something called posterior probabilities. So that is called posterior probabilities, and it is specifically related to Bayesian analysis. Yeah, not the traditional statistical analysis which we perform. Yeah.
Great. So I think we come to the end of this presentation. Anand, thank you so much once again.
Thank you,
for your the insight into this all of this that you carry is fantastic. Thank you so much.
Thank you, sir.
The next presentation is by Professor Debasish Hota, and the topic is Principles of Palliative Care Drug Use. I have known Debasish for many, many years, more than 20 years now, and it's such a pleasure to see him rise. He's now the head of department at AIIMS Bhubaneswar. Debasish, we look forward to your presentation.
And good afternoon to all. Professor Dhaneria, nice to see him after a long time. Dr. Vishwas, Shanish, and all my dear future colleagues, my present colleague Anand, Shambhu, etc. I missed Dr. Tripathi, he must be busy in organizing certain things. Yeah. So the topic is somewhat neglected topic, what happens to this end of life care. So people send them home, patient admitted into the ICU, then they say there is point of no return, patient sent back home. So this appears little inhuman, unethical, but hospital also has its own limitation, the physicians have their own limitation. They prefer to spend more resources and time on a younger person or younger patient rather than a patient who is old, debilitated and who has no meaningful life left. But we cannot leave a patient as such. Death is inevitable, no doubt. But managing the end of life care is also important so that he can make a meaningful and peaceful exit from the. So that is what all about the palliative care, and we will. And here is something to confess. And this is the first publication I made during my second year of MD. Professor Salil Bhattacharya was professor in BHU. So he told me, you write this paper in 15 days. I have no idea where to collect the material, what to do and how to proceed. But he was very good enough to give me few books on palliative care. And I have to write 15 pages out of it in double spacing typewritten. That time we didn't have computers, we have to submit the handwritten manuscript to someone and he will type, we will edit and re-edit and re-edit. So this is something very close to me, and when Shambhu requested me for this, I agreed. So there are models, what is palliative care, I will discuss on that, objectives, components of palliative care, symptoms, and the most common symptom that the end of life patient needs is treatment for pain, dyspnea, GI symptoms, nausea, vomiting, constipation, and psychological symptoms, especially delirium and anxiety. And drugs are also no saints, they also have their own share of adverse events, and we have to manage that also. And finally, I will summarize it. So this is something, the active total care of patients whose disease is not responsive to curative therapy. That means patient is refractory to all kinds of treatment, and basically we need to control the symptoms what he is having, because we know the path is now blind and there is point of no return achieved. So there is sociological, psychological and spiritual issues that may be there, and we have to look into all these. So models of therapy. So there is a curative therapy, that this blue line, I didn't get that. Yeah, this curative where disease specific and restorative, the first dark box. Then there is a palliative care where that white big triangle, that is supportive and symptom oriented. So where we can control the symptoms without having a specific cure, we can just manage the symptoms. And first, once the death occurs, there is how to manage the family members and bereavement symptoms. So it is, yeah.
Other people can see.
Okay. Then, so this is with persons with illness, there may be cure or there may be death. And after death, there is supportive therapy for the caregivers. They also need assurance because they lose someone very close to them. And the disease progresses and finally the inevitable happens. And what is the goal? To provide a quality of care. Here we miss certain things. There is no specific therapy for this. You cannot conduct any clinical trial for palliative care services because you know the disease is irreversible. Only symptomatic and supportive care is permitted, and we cannot experiment on a patient who is almost dying. Of course, certain cases we can go for it, like cancer therapy. So most of the therapies are limited and we can do that. Like a person with meningeal metastasis, we can go for certain therapy like radiation therapy or something. That is actually not a palliative therapy, it is suppressive therapy. But palliative therapy comes after that. If everything fails, then we'll go for that. And the history of palliative care starts with this British lady, Cecily Mary Stokes Saunders. And she was actually a nurse, and she was giving care to a Nazi survivor who escaped from Auschwitz, from Poland, and he was admitted. Finally, she fell in love with the patient and she developed this specialty. So this is the hospital, and she started. Now it has become a worldwide phenomenon to provide palliative therapy, but there are certain riders. In India, palliative care is actually non-existent, and there must be something to be done because hospitals are overburdened, doctors are limited, and time is very, very less. And patients also do not know that this palliative care, what do they do? Once the patient is discharged from the hospital, there is a big crisis at home. What is to be done next? They just appoint one nurse who just does the basic life support, like changing the linen, changing the diaper, and all those things that she can do, or giving the medicine as prescribed. That is something the family expects, and that also takes its own cost. Then communication, how to communicate the bad news. Here the role of the caregiver comes that yes, you have reached the point of no return and you must be prepared mentally for the situation. Symptom control, because varieties of symptoms can occur because there are problems of end organ damage, problems of drug adverse events, problems of psychological issues and family issues, negligence, all those things that are to be addressed. Then rehabilitation, is there any possibility of recovery, or patient also, if he is conscious and he is understanding the situation, yes, he can be made to understand the situation. And terminal life care, support in bereavement family members, Because now doctors are continuously attacked by the caregivers or their family members, by the patient was alive and very much talking, conscious, and in the hospital you have given medicine and you killed my patient, my parent or somebody else. So that has to be again, because of the communication only, where the doctors are not tuned how to communicate and how to convey the negative news. If it is cure, everything is fine, surgery is successful, they go happily. But if something is not possible, despite giving all the best therapy available at the moment, so that has to be communicated to the family members and the patient's relatives. And education is needed for both the physician and the caregivers and also the family members. They all need to be educated how to behave in a situation like this. You suddenly cannot convey that, yes, we have done whatever we could have. Now it is point of no return, take back your patient. That will create some anger, some frustration among the family members. That is again will be reflected very badly in the media or in the direct action on the hospital. And research, here I emphasize research is very, very limited in the palliative care setup, and it is a basically neglected area of research. A lot of things can be possible by pharmacologists and clinical pharmacologists, because you have variety of disease, variety of organ dysfunction, variety of symptomatology, and variety of drug therapy and drug induced adverse effects. So a lot of things are in sequence and lot of things are still unknown. We cannot do a magic, but we can still provide some relief here. So to domains which we need to focus: physical symptoms, especially the pain, anxiety, delirium; psychological symptoms that come next to it; then social needs, interpersonal relationship. So when all the relatives start visiting the person who is dying or person who is just discharged from the hospital, that also creates anxiety. We must limit the number of visitors. We must, that so much live sympathizers, that must be limited. And patient must be given adequate freedom to express his views. We only just see one side of the story, that the doctor has come and given some medication and discharged. But what happens to the patient himself? Have we taken any opinion from the patient? That makes some difference here. And existential and spiritual needs, although that is a WHO definition, physical, mental, social, spiritual, all these things come together. Therapeutic part comes only one domain. So common symptoms what the patients usually have: pain, lot of symptoms they are focusing on or related to pain; dyspnea because of this cardiac or respiratory problems; constipation because of the drugs or because of the disease process the patient is having; nausea, vomiting, that may be part of the disease, part of the drug; anxiety, delirium. These are the 6 major symptomatology, but anything else can be possible. There can be heart failure, there can be edema, there can be renal failure, other things that will also ensue. So almost 2/3 of the patients with advanced cancer, they experience pain. It can be meningeal metastasis or metastasis to the bone or any other soft tissue. So 30% they relate it as moderate to severe. That means 1/3 of the patients they perceive as moderate to severe and they need therapy for the control of pain. So it can be either nociceptive pain like achy, throbbing or dull pain, or it can be neuropathic pain. There is damage to the neuron, or where there is a repetitive firing from the dorsal root ganglion which continuously stimulates the pain sensitive pain receptors in the brain, and that needs a different formal treatment. Then assessment of pain. Pain is more when the person is alone, where pain is relatively less when the person is in the company of his loving family members. Then timing of the pain, when the pain starts, when the pain wanes up, whether it is a continuous pain or whether it is a dull aching pain which comes off and on. Then the severity of pain, and we don't have a measure of pain except the visual analog scale, so we can quantify the pain. And how the patient describes, if the patient is in a position to describe, it is a good situation, but many patients, suppose a person who has undergone resection of the tongue or who has just developed some signs of Parkinsonism or psychosis, he may not be able to describe the symptoms he is having. Then location of the pain, where the pain is located, nature, that has to be ascertained so that we can do something. Maybe a nerve block can relieve the pain if it is located to a particular site. Then what are the precipitating factors that can aggravate the pain or relieve the pain? Then radiation, if it can be assessed that it starts from a particular organ, then it radiates to others. Like a cardiac pain usually originates from the sternum, not from the left side of the heart, what movies show, and it goes to the left shoulder or left limb. Then how much functional aspect is impaired due to the pain? Maybe he is unable to move his side, maybe he is unable to lift his limb, or if he is unable to take his feet, how much care he needs because of the pain, that has to be assessed. Then nociceptive pain, non-opioid analgesics are usually the first choice, usually paracetamol, but with a word of caution, if the liver function is good, we can give paracetamol. There is a limit, not more than 2 grams a day. Then NSAIDs, because they have their own adverse effects, they have renal adverse effects, GI adverse effects, and cardiovascular adverse effects. So we have to again be very, very careful about use of indiscriminate administration of NSAIDs. And WHO pain scale, it has step 1, 2 and 3. Step 1, that is non-opioid for mild pain, nociceptive pain. For mild to moderate pain, there is weak opioid and non-opioid adjuvant therapy, that means mixture of NSAID and mild opioid. And moderate to severe pain, when it is refractory or not responding to mild therapy, so we have to go for strong opioids, then we will go for this last. And in refractory pain, there is no limit of opioid dosing. We can increase because we know that pain is not responding. We cannot leave the patient unattended without relieving the pain, or he can take as much opioids he can. So there is no maximum ceiling dose to opioids, and it should be titrated, of course, that what is the lowest dose that relieves the maximum pain and makes the patient comfortable, and how much adverse effect the patient can have. Because one of the possibilities that there can be dyspnea or breathlessness, then if the patient is prescribed opioid, that may aggravate. The problem is opioid silence the respiratory center, patient may not get the symptoms of this carbon dioxide accumulation, so that is a problem. It makes the respiratory center insensitive to carbon dioxide, which is the potent stimulus to the respiratory center. Is it over or can I continue? Yes, sir. Okay, thank you. So, after initiating every dose of opioid, the patient needs to be evaluated for both pain relief, efficacy and the adverse effects. Common adverse effects that everyone knows is constipation, which can be troublesome in a patient who is bedridden, or it can be respiratory depression, which can be more troublesome. And how to escalate the dose? For mild to moderate pain, 25 to 50% dose escalation may be appropriate, but in severe pain, 50% should be the starting next dose to access. Then neuropathic pain, that is my area, my focus is on neuropathic pain throughout. So tricyclic antidepressants like amitriptyline or SNRIs like duloxetine and alpha-2 delta ligand agonist like this pregabalin and gabapentin. And second line, we have traditional analgesics like tramadol, tapentadol, that is a more NRI, that is more is mu opioid receptor agonist and norepinephrine reuptake inhibitor like SNRI, so it has dual function. And third generation therapy for this neuropathic pain is opioids, oxycodone or morphine, but again be prepared for the adverse effects. And designing analgesic regimen, so scheduling the round the clock. If it is continuous pain, then round the clock analgesia has to be given, then rather than as needed, because round the clock is beneficial. It suppresses the pain that appears before, that suppresses the pain before the pain reappears, so that has some benefit. And all analgesics work less during pain. So if we can give the pain analgesic before the pain appears, it has a better control over the pain. So long acting or extended release analgesics, opioid analgesics are preferred for round the clock pain control. And for breakthrough pain, we have short acting opioids that can be given along with the long acting opioids, so that we will have a better control over the pain. But be prepared for the adverse events. So continuous pain, long-acting opioids, then for breakthrough pain, short-acting opioids, and these are the problems. Opioids are very well known for their adverse effects, that constipation, which can be very, very troublesome, sedation and confusion. And respiratory depression, so it always preceded by sedation, thus one has to be very, very careful about it. We have some relief for the constipation. We have GI specific mu opioid receptor antagonists like albumopan and methyl naltrexone, so that will take care of it. And dyspnea, advanced cancer, particularly metastasis to the lungs or the great vessels, that can suppress the respiratory or airway function. Then advanced cardiac and pulmonary disease, heart failure, COPD, they can produce dyspnea. And dyspnea management, again, opioids, although they can produce dyspnea, we have to be careful, but they have excellent effect if it is due to ventricular failure, and if the dyspnea is due to the left ventricular failure, it creates oxygen deprivation, carbon dioxide accumulation, and opioids, by suppressing the respiratory center, they can decrease the anxiety, so the sympathetic flow will be reduced and the heart will get some rest to provide the relief, and by that we can indirectly stimulate the parasympathetic system, and that will be beneficial in this scenario, but it is only for a brief period. It cannot be given continuously. So for refractory dyspnea, it can be used. And second, third line agents, benzodiazepines along with opioids, but preferably short-acting benzodiazepines can be preferred. We should avoid drugs like diazepam or lorazepam. We should go for short-acting, like midazolam, that can be useful. Then this dyspnea, so basically it reduces the sympathetic drive, vasodilatory effect in the pulmonary vasculature, so it improves the oxygenation, then changes in the effect on carbon dioxide, oxygenation and inspiratory flow in the resistive loading on ventilation. So these how mechanisms how affect the respiratory function and improve the respiratory function even if there is severe dyspnea. And non-pharmacological, like use a fan to create air movement across the patient face, so that helps little bit, and frequent repositioning of the patient to prevent the stasis of blood, particularly in the lower part of the lungs, and pulmonary rehabilitation. As you can remember that during COVID, patients with severe respiratory dysfunction were asked to reposition themselves in the prone position because that allows more ventilation, and this mechanism can be applied here. and supplemental oxygen if the PO2 is less than 25 millimeter mercury. So that has to be again be handy. Constipation, so this is not due to this IBS, it is the drug induced constipation, or it can be the disease specific. So we have to manage. If it is due to disease specific, we have to look for specific drugs, and if it is due to opioids, we can have management like GI specific mu opioid receptor antagonist. So for disease specific, obstruction to the gut by cancers, maybe obstructive symptoms, electrolyte abnormalities, so we have to check for that, impaired venous flow due to heart failure and gut wall edema, all can affect the GI motility, digestion and the movement. And drugs, opioids are the most notorious, but tricyclic antidepressants which are used for neuropathic pain, they have this anticholinergic adverse effect, atropine-like, they can also produce constipation. Then antiemetics, they can have this constipating effect. Anticholinergics, of course, they have their own set of side effects. Then what the patient will have, patient will not pass any stool, so there may be hard stool, so painful or infrequent defecation and sense of incomplete evacuation of the bowel. But if he strains, there will be more pressure on the venous system, heart, and the things can go worse. Particularly patients following myocardial infarction, straining is absolutely not required, but we have to manage the bowel. So non-pharmacological like intake of fluid, but intake of fluid cannot be indiscriminatory, because if he has heart failure, then, or if he has pulmonary edema, we cannot increase the fluid intake. Fluid intake should be increased to a limit that does not worsen the dyspnea, but improves the bowel movement. So some kind of physical activity, maybe some kind of passive exercise is advised. Laxatives, but irritant laxatives are to be avoided. So lactulose, senna, magnesium hydroxide is actually an stimulant laxative that has to be restricted, but may be required in certain cases along with liquid paraffin. Then dioxyl sodium sulfosuccinate, doxate sodium plus senna, and but there is no difference in their efficacy, so it has to be given because constipation needs to be addressed. And those receiving opioids should receive prophylactic stimulant laxatives, because we know that opioids are notorious agents for causing constipation. Then there is role of methyl naltrexone, as I have described. It is a gut-specific mu opioid receptor antagonist that takes care of the GI movement suppression of the opioid, but it will not affect, because they are not absorbed from the gut, they will not affect the analgesic effect of the opioids. So these are the drugs, methyl naltrexone, naloxone and albumin. They are all approved by the FDA and CDSU, so we can use them. So these are peripheral opioid receptor antagonists, and they also take care of the pruritus by the opioids. Nausea, vomiting, that is another big area. So nausea, vomiting, most drugs cause nausea, vomiting. Any drug crosses the blood-brain barrier can cause nausea, vomiting, that the traditional pharmacology treatment says. Also there may be meningeal metastasis to various parts. Even if there is some metastasis to the vomiting center or the CTZ, there can be persistent nausea, vomiting. And the taste, there can be the GI effect on the drugs, they can also induce nausea, vomiting. So D2 blockers like haloperidol should be considered, and we have to give some drugs which will not affect the GI motility, but all these drugs like haloperidol, although it is very effective suppressor of nausea, vomiting, it can also produce gastroparesis, so that can be again aggravating effect on the nausea and vomiting. So we have so many drugs like opioids, antimicrobials, antidepressants. So they target this receptor, D2 receptor, then 5-HT3 receptor, NK1 receptor in the CTZ, and impaired gastric emptying, 5-HT4 and dopamine 2, and 5-HT3 acetylcholine muscarinic receptor. So we have certain drugs like ondansetron here, or aprepitant, then fosaprepitant, then prochlorperazine, promethazine, so they can be used here in case of nausea, vomiting. Then others like cranial, intracranial pressure, CNS, so we have chlorpromazine or promethazine or D2 receptor antagonist. So scopolamine, promethazine, they are not
Debasish, you need to go a little fast. How many
yes,
more
yes,
slides?
only few are left.
Few more.
Yeah. Anxiety, benzodiazepines are excellent drugs for treating anxiety, but we will go for only alprazolam, not the long-acting benzodiazepines like diazepam, although it has good effect, and may be combined with SSRIs, but no drug is a saint. Every drug has its own set of adverse events, so be careful about the adverse effects. Delirium, so uncontrolled pain, or there can be constipation, infection, electrolyte abnormalities, opioid withdrawal. So lack of sleep, all can induce delirium, and that initially people take it lightly, but should not be viewed lightly. So acute decline in attention or consciousness with cognitive dysfunction, that is there. Management, benzodiazepines or opioids, anticholinergics. Then first generation antipsychotics are excellent agents to control delirium, but if it is due to hypoxia, oxygen therapy may be administered. Then while prescribing medicine, as the traditional pharmacology says, the risk versus benefit. How much benefit do I get? The benefit must outweigh the risk, that is why then only I can go for a drug therapy. And when there is a terminal event, we usually administer so many drugs, and they have their own set of adverse effects, and more than 25% of the adverse events are attributed to the drugs itself. So what we can do? Reduce medication burden, so decrease, so that can be deprescribing. So drugs which are not producing effect, we can deprescribe, so that will reduce the medication burden, decrease mortality, reduction in the hospitalization, and possible improvement. I cannot say there is definitive improvement, there can be possible improvement. And candidates for deprescribing, those who have no indication, like PAN 40, that is the common drug which is prescribed in most hospitals without any indication. Every patient hospitalized is prescribed pantoprazole, I don't know why. Now people are switching over to rabeprazole, stating that it has a better effect. I still could not understand what is the better effect is. So we can de-escalate. If only there is hyperacidity, we can think of using that, otherwise we should avoid. Then beneficial drugs will be kept, and those who are not producing effect, we should de-escalate or deprescribe. Then end of life care, that intesol formulation, this intesol we have dexamethasone, so only high concentration oral preparations are there, which are well observed and which are well documented to be effective. So they can be given, that is the end of life care. And goals of care, what we exactly mean by goals? We should achieve a peaceful exit from this immortal or mortal world. Nobody is immortal. And spiritual consideration, people call maybe the priest to give some end of life advice like citation of Gita or Bible. That may also help to make a peaceful exit. And symptom management, then attention to the quality of life and alignment of the treatment with patient identified goals. And palliative care must ensure that the treatment provided to the patient with serious illness are consistent with the patient's goals of care. Patient must ask for something, patient may not ask, but the physician must also visualize certain things from his own experience. So that's all about the palliative care, but we are still missing many points, and every patient is different. No drug fits all. So we have to individualize the therapy, and the palliative care for a patient with heart attack may not be similar as a patient with cancer. So it has to be discriminated, and specific therapy must be instituted, and we must individualize every patient for its care. Thank you. I took little more time because I got little emotional because it was my first publication. Anyway.
Now,
Thank
wonderful
you.
presentation, Debasish. Thank you so much for such an important topic. It's so important because, many of us here sitting here are in an age group where we have very elderly parents, and so this personally affects some of us. I have a question for you, first of all. So opioids are so important for palliative care. They take care of pain as well as dyspnea. Many patients will require opioids. Yet, the regulations around opioids are so tight that often, they become unavailable to patients who are being, end of care or palliative care is often in the home setting. Getting those opioids becomes difficult. So what is the latest regulations around opioids? If I have a patient at home, and I have a prescription from a doctor, can I procure opioids, and where can I get them from? How to do it? Can you
True,
just
sir.
give us?
They are not available in the market. Only specific anesthesia department people are authorized to dispense. Not even the pharmacist can dispense. So the pharmacist will take the permission from the anesthesiologist who is in charge of that hospital, and a committee is usually there for opioid dispensing committee in many places. They will distribute if it is needed. And
That's where the problem is, because the patient is a Calcutta patient, has gone to Tata Memorial Hospital in Bombay, got treatment from there, got a prescription for opioids for palliative
That
care,
is
comes
the
back to Calcutta.
point, sir.
Where is the hospital? I can't go every time to Tata Memorial Hospital to get the opioid. And any other hospital will probably not give that
They
to
will
me,
not
because
give.
their anesthesia department will say, you bring the patient here.
these
Is
are
there something
some
being done
gray
about this?
areas, I understand. So there is no straightforward answer to your question actually.
Please. You're in a good position to react.
No, in fact, there is some provision, like when I was in IGMS, he's absolutely correct that this anesthesia department, they do this palliative treatment. And you have to take an extra permission from the authority that we are treating these patients, and there are supplier also. Need some extra work to do, because as it is drugs which may cause abuse, misuse, and that's why this regulation is there. Otherwise, anybody can go and can buy from the market and do some.
Yeah, well understood.
So that is one problem. Yeah.
But the issue is, on the one hand, to stop misuse, something which is so important for palliative care, and you're talking of elderly people in their last phases of life. If you can't do this much for them, then what are we good for?
No, there is way. No, people are getting. Either they are not going through.
I know. But
through proper
I'm
channel.
telling
Proper
you-
channel. Yeah.
I'm telling you, the most situations in which patients find themselves, at that point of time, the patient is not in a position to move. A. Number two, his family is harassed, hassled, is going through a very difficult time. And that point of time, it can't be got from the nearby pharmacy. I think at least this much can be done, that if a prescription is there from a bona fide hospital, then another hospital must be made to honor that prescription. They cannot say that you have to bring the patient here and we will see
it's
them.
not there. You don't need to get the patient to the. If you show the doctor's prescription, it is available.
But that's what I wanted
Yeah,
to
it's
know,
available.
because there was
It's
a time when it
available.
was not available.
Yeah.
I recall that
It's
you have
available.
to go to a government hospital, get something from a superintendent,
available.
they will supply it to you.
Okay,
But it is a lot
because-
of pain
Yeah.
actually.
Time is short, but
Yes, sir.
just few points
Sir.
I noted down. It's really important, as you told in the beginning, that it's very neglected, but there should be something to do, because very few places this MD course is there. In names Dr. Sushma Bhatnagar, who is now head of the IHCS. She started MD course in palliative medicine, so NMC should take care of it. Like NMC is now giving more importance for emergency medicine. It is a must, mandatory in every medical college to start MD. And Superspeciality DM critical care medicine is also there. They should take more initiative to do more, at least if there are MD course, so student will be there and it will spread throughout the country. And very few places are there, like in AIMS in the ring road you have seen that Santi Avant Ashram, Santi Vedant Ashram. They do this type of hospice and other works. When I was in Patna, now we have also started on palliative management in the Mahavir Cancer Hospital. But there should be more like that to take
We
care
have
of
to involve all
palliative
the
care.
practicing
Yeah.
physicians to
Yeah.
take care of this,
Yeah.
because patient cannot move around and the attendants also cannot move. So we have to have a mechanism so that they can get the uninterrupted supply of the essential drugs that they need.
All right. Thank you.
Thank you, sir.
Thank you, Debasish, for the wonderful presentation. Very important topic. Let's, progress, and I would encourage you. You are in this, or at least have thought about these areas. Work towards changing or improving our systems, so that these things become much easier for people who are
That
really
is
in
the
need. for
legal
them.
and technical aspect of this
Absolutely,
opioid distribution
absolutely.
and management chain.
Absolutely. Thank you so much for your wonderful presentation. Thanks. We come to an end of this session. Are we breaking for lunch or?
Yes.
Huh?
So may I request Dr. Shoibal Mukherjee sir to please felicitate Dr. Anand Srinivasan. Also may I request Dr. Shoibal Mukherjee to felicitate Dr. Debasish Hota sir. Thank you, sir. Thank you very much. Yes. So now we will have a break for lunch, and after that we will have the keynote lecture. So may I request our online participants and online faculties that we will take a break. We will be back by 2:10. Thank you all.